Hey everyone, welcome to our COPD lecture. Last lecture we talked about a whole bunch of different restrictive disorders. We're just going to really be focusing on the one obstructive disorder, COPD. And there are two primary causes, inhalation factors and genetics. Inhalation factors typically refers to smoking. It could potentially be pollution as well. 40 pack years is highly predictive of COPD. If you guys aren't familiar with the pack year terminology, this just refers to a basic way of calculating how much smoke someone has inhaled over the years. And so you take how many packs a day they've smoked times the number of years they've smoked, and you get a pack year estimate. This can vary from year to year, so you might need to add each year up individually, or maybe they smoked 2 packs a day for 5 years, that's 10 pack years. And then that bumped up to 4 packs a year for, 3 years, and that's another 12 pack years, and then you just add the years up year by year. But anyway, if that adds up to 40 pack years or more, chances are very good that they will have developed COPD. Genetics plays a big role in that. Genetics can influence how many pack years are necessary for COPD to begin. Although genetics is rarely the cause, it can certainly influence or predispose someone to developing COPD. But more likely than not, smoking is the primary cause. However, your genes will influence whether that happens at 10 pack years or 80. So a typical lung function for someone with COPD is characterized by hyperinflation. The alveoli are inflated, and air is sort of trapped inside, and the patient can't get the air out. The shoulders are often elevated, ribs are horizontal, they have a barrel-shaped thorax, low flat diaphragm, and decreased oxygen saturation. And you can really see the barrel chest in this image. And we typically think of increased lung capacity as a good thing, but in this case, that air is trapped inside. We can't get it out, so that is certainly not good. And that's really reflected in the pulmonary function testing. So a normal FEV1 FVC capacity is being calculated down here. So they exhale 3.3 liters in a second, and the total expiration is 4 liters. So that's an 83% ratio, and that's normal. 0.75 to 0.85 is considered normal. We don't really start to characterize something as pathological until it gets below 0.7. And so let's go over to restrictive now. Actually, obstructive and restrictive both. You can see there's a decreased volume of air being expired. In the case of restrictive, it's because the actual chest wall won't expand. Or it could be because there's a tumor or fluid. Something is preventing expansion of the thoracic cavity in the lungs themselves. And so they can't get air in. And since they can't get air in, they're not able to exhale that much. With obstructive, the problem is lung capacity is huge. They just can't get very much out. So in both cases, volume of expiration is low. What changes is with restrictive, the FEV1 FVC capacity is preserved or sometimes elevated. In this case, it's elevated 90%. With obstructive, it's very low. In 1 second, they can only get out 1 liter, and it takes them, apologies. So in 1 second, they can only exhale 1 liter of the total 2 liters. So that's a 50% ratio. And that's because it's difficult for them to get air out, and it's difficult for them to get air out quickly. They really have to labor to get the air out. So a normal value is greater than 75%, 75 to 85. Higher than that is indicative of restrictive. Lower than that is indicative of obstructive, especially if it's lower than 70. So lung volumes kind of are the opposite. It's an increased lung volume, an increased residual volume, especially because the air is trapped and the lungs are hyperinflated. So increased TLC, increased RV, decreased FEV1 VC ratio. Now, COPD is the third leading cause of death in the world. It's unbelievable. Oftentimes, first world disorders and third world disorders are very different. This is one case where smoking is kind of a worldwide phenomenon. So it's pretty widespread. And it is one of those rare, easily preventable disorders. It's also treatable to an extent, but it's easily preventable. And you just have to address the issue of smoking. Now, it's a mix of parenchymal disease. Parenchymal disease is when the gas exchanging portions of the lungs, the alveoli, and some of the really, really small airways are no longer functional. And it's also a combination of small airway disease, in this case, obstructive bronchitis. Emphysema is a smoking-related disease. It's inflammatory destruction of alveoli. And what happens is the alveoli increase in size, and one of the reasons they really increase in size is the intermediate partitions are ruptured. So you can see here, this would normally be 2 alveoli, but now it's 1 because this intermediate partition is destroyed. This might be 3, but again, now it's 1 because that partition is destroyed. That traps a lot of air inside the lungs. Chronic bronchitis is a lot of inflammation and mucus. Hypertrophy of the submucosal glands is a typical presentation associated with chronic bronchitis. It's defined clinically as a chronic productive cough for 3 months in each of 2 successive years. And so COPD is kind of a combination of emphysema and bronchitis. So it's more of a disorder than a specific disease process. It's a combination of multiple disease processes associated with smoking and air trapping. Treatment for COPD involves a lot of secretion clearance techniques, breathing techniques, and disease management, disease self-management. And we'll talk about this a little bit in class. And that brings us to bronchiectasis. Bronchiectasis is a permanent pathological dilation of airways. It's not really a specific disease process. It's more a collection of different diseases resulting in a broad category of injury. Basically, any disease that causes chronic, severe coughing has a tendency to injure airways. And that brings us to the causative mechanism of bronchial wall injury. It can also be caused by traction from adjacent fibrotic plaques that create tensile forces and cause injury or obstruct the lumen of the airways. A common symptom of bronchiectasis is a chronic cough with chronic sputum production. Next, we have cystic fibrosis. Cystic fibrosis could really be a chapter in and of itself, but we are forced to limit it to one slide, so we'll just kind of cover some of the basic features of cystic fibrosis. It's often spoken of as if it were a lung disease only, but it actually affects every body system with epithelial surfaces. And it's also the most common life-threatening disorder in the Caucasian population. It's caused by a mutation to a specific gene that codes for a transmembrane protein, and the result is a disruption of chloride balance. So some of the symptoms include very salty sweat, sinus problems, frequent infections, trouble breathing. Pancreas function is a big issue. There's a lot of pancreas enzyme replacement therapies that have to take place in someone with cystic fibrosis, and that leads to digestion problems due to the lack of pancreatic lipase, all sorts of problems. One of those is a large amount of mucus in the lungs, and so a way that PTs can get involved is by performing postural drainage and percussion, shaking and vibration to clear the lungs. And we'll talk about all these different types of lung drainage techniques in lab in a couple of weeks. Two devices that are really popular are the Acapella or Arabica device. You can Google those. They're just little devices that you exhale through. One of them creates a fluttering, and that alteration of positive and neutral pressure can loosen mucus, and both provide PEEP, or positive end expiratory pressure, which is another thing that PTs can get involved with, as well as thoracic stretching and inspiratory muscle training. Asthma is a very common disorder, affecting 8.4% of the U.S. population. It's one of these diseases that we don't really understand the cause. And most diseases that we don't really understand the cause of fall into this gene-environment interaction category. What that means is we know there's a gene component, but it's not completely explained by genetics. As soon as we think we've identified a gene that explains asthma, we find that only some people with that gene get asthma. So we know there's some kind of gene-environment interaction. It's a very broad disease. Kind of the key component across all of the different asthmatic disorders is airway inflammation. And you can have acute attacks, which consist of chest tightness, difficulty breathing, wheezing, and you can have acute attacks over the course of years, leading to chronic asthma, which causes sometimes irreversible thickening of the airway walls, which results in narrowing of the airways. It can be exercise-induced. I experienced exercise-induced asthma as a child. So did my daughter. She's still a child. She's 4, but around the age of 2 and 3, she had exercise-induced asthma, and it's gone away. You can also have cold air-induced asthma. Many people who don't consider themselves asthmatic have experienced cold air-induced asthma. They just assume it's a typical response to cold air, but it isn't necessarily. It can be infection-induced or allergen-induced. A common treatment will be some type of acute respiratory inhaler like an albuterol that causes airway dilation. There's also an array of chronic medications that can treat asthma and reduce the likelihood of acute attacks. Pollution is a big issue as far as asthma is concerned, and other environmental factors. The specific environmental factors that cause asthma, though, are unknown. And guys, that's it for this lecture. Thank you for listening. There is a case study on page 210, which I think is a really, really good example of a specific PT evaluation of an asthmatic patient. Please take a look at that. There's no assignment to turn in, however. There's also no study guide in your text for this chapter. We'll just have a short quiz, just a few questions. It's really primarily one disorder, which is COPD, with a couple other slides on some other disorders like asthma and bronchiectasis. So not a whole lot in this lecture. I appreciate you guys listening, and I will see you on Thursday. Have a good one. Take care. Bye.